So as we continue to talk about oxygenation, we need to talk about our medication delivery systems and other things that we give as well. So we're talking about small volume nebulizer. We would use this to give albuterol or duoneb, uh, potentially racemic epi, um, and it contains the nebulizer chamber itself holds 3 to 5 milliliters of fluid. They're attached to a face mask or a pipe or a mouthpiece that delivers medication in an aerosol form or nebulization that is more likely to pass through the upper airway to the lower airways. Pressurized oxygen or air enters into the chamber to create a mist, and we're looking at 6 to 8 liters per minute usually to properly nebulize the medication, which the patient then inspires or breathes in. Oxygen is the usual carrier, but air occasionally is used in COPD patients. Unless your trucks have medical air on board, I wouldn't worry about it. Some services have medical air compressors on their trucks, and you could use that in place of oxygen. However, if your patient needs oxygen, this is another way to add oxygen to that while delivering medication as well. There's a heliox or helium oxygen mixture that can be used in patients with upper airway obstructions. Then we move on to oxygen humidification or oxygen humidifier. We can provide a humidified oxygen, especially if we're providing high flow O2 through a nasal cannula. So a normal nasal cannula is up to 6 liters per minute, and at anything over 4, I would think that we would need to, especially if it's going to be a long distance, we need to, or a long transfer time, we need to put them on humidified oxygen to try and prevent those nasal passages from drying out. Basically, this comes in a reservoir that has sterile water in it. We give humidified oxygen to pediatric patients with upper airway problems, such as croup. There's no evidence that this improves outcomes, but I think it helps the patient feel a little bit better. Humidification is also used for patients receiving long-term oxygen therapy to prevent complications of drying out the mucous membranes. It's rarely necessary in EMS unless you're doing a long-distance transfer. So that's something to keep in mind. Positive airway pressure is delivered via face mask to maintain constant levels of pressure within the airway. So, which assists the patient in breathing by preventing collapse of the airway during inhalation. So, CPAP, continuous positive airway pressure, maintains a steady level of pressure during both inhalation and exhalation. So, once you set that pressure, it stays constant. And the patients that need CPAP tell you they need CPAP. And if they don't know they need it, but their body knows they need it, once you put it on and the patient adjusts, they know they need it, and they will actually calm down. They will adjust to it, and they will breathe, and they will actually start talking to you. It's actually quite amazing. Bilevel or positive airway pressure or BiPAP maintains a higher level of pressure during inhalation and a lower level of pressure during exhalation. So if you got patients that are, this is something more in the ventilator area or respiratory therapy area. I don't know of many services that have BiPAP on a 911 truck. I'm sure that it's possible. And more of your high-speed services, more of your big metro areas may have these, but they sense when you're taking a breath in, and it increases the pressure to force air or force oxygen and air down into the lower airway and really push those open. But you may not need as much pressure and expiratory pressure or pressure against exhalation. So once that breath has been taken, the pressure drops, so it's easier to exhale. CPAP and BiPAP use oxygen in conjunction with increased airway pressures to minimize atelectasis.